Committee will come to order. I'd like to thank the witnesses for remaining, and I'd like to begin by asking Mr. Cannon. Under what circumstances do you see that that making private health insurance compulsory represents a bailout to the insurance industry? Could you explain that view?
Well, Mr. Chairman.
And hold the mic a little bit close, okay?
Certainly. Mr. Chairman, in order to help Americans comply with what they call the individual mandate in the legislation before the House, and there's one in the legislation before the Senate as well, Congress has decided it would, or the legislation would offer subsidies to Americans to help them purchase health insurance. Simply mandating that people purchase health insurance doesn't mean that they'll be able to. A lot of people won't be able to afford it. And so Congress would be, in this legislation, offering subsidies to a lot of people who cannot afford health insurance on their own, and to a lot of people who can afford health insurance on their own, because the subsidies, as I understand them, would go up to 300 or 400% of the federal poverty level, which for a family of four is somewhere around $60,000, $80,000 per year. Those subsidies, offered to people who can afford health insurance already and to people who cannot, would essentially help people purchase more health insurance and give the insurance industry really a guaranteed customer base and a guaranteed source of revenue. So I think that essentially what that legislation would do is akin to a bailout of the health insurance industry. I don't think that what we should be doing is giving more to this sector or to this industry. I think we should be demanding more from it, and I think the way to do that is to preserve the choose whether or not to purchase health insurance, as well as the freedom to choose what goes into your health insurance policy. And the way to do that, in my view, is to let consumers control the money that government and employers now control to purchase health insurance on their behalf. And they will economize on health insurance. They'll purchase most likely purchase less health insurance than they do right now, and they will hold health insurers accountable in a way that they cannot when their employers are making those decisions for them.
So let's go 4 years down the road. Let's say that a health care plan is enacted which requires that people have private insurance. Let's say there's no public option. That's kind of the way it looks like right now. And there will be tens of millions of Americans who will be faced with a decision to either purchase the private insurance or pay a fine. Mm-hmm. Would you like to comment on that?
I think that what that really highlights is that this proposal to mandate people purchase health insurance, this proposal to make health insurance compulsory in the United States, amounts to a tax on a lot of middle-class families. If they purchase the health insurance, as President Obama's economic advisor Larry Summers acknowledges, when the government forces people to purchase something that they don't value or pay more than the market would demand, that is in itself a tax. But if they don't purchase the mandatory level of coverage and they have to pay what we euphemistically call a fine or a penalty, that's a tax as well. And in the House legislation, there would be a tax on the individual equal to 2.5% of income, of adjusted gross income. And if the individual's employer does not offer them coverage, there would be a tax equal to 8% of payroll. Now, Mr. Summers and the Congressional Budget Office and economists broadly acknowledge that 8% payroll tax would be paid for by the worker because it would reduce her earnings. So what you're talking about there is a 10.5% tax on the uninsured.
Is that axiomatic?
It is.
So you're saying that if workers have a health care benefit, they're in effect paying for it?
Absolutely, and I think in fact that is why I think that's the great the biggest drawback or the biggest problem with the tax preference for employer-sponsored insurance. The quote-unquote employer contribution to the average family plan in this country amounts to $10,000. That's $10,000 of the worker's earnings that the worker doesn't get to control. The government, by creating this tax benefit for employer-sponsored insurance, essentially takes that $10,000 out of the worker's hands, gives it to the employer, and lets the employer make the worker's health insurance decisions for the worker. So yes, I think that economists, in fact, there was a survey of health economists recently, and the broadest area of agreement was on the question of whether health benefits actually come out of wages or profits or something else. 90% of health economists acknowledged or agreed with the proposition that yes, workers pay for those health benefits through reduced wages, and the same is true of any tax penalties that Congress might impose.
Thank you, Mr. Cannon. Professor Politz, I want to speak to you about how government can help the public make better choices about health insurance. In your testimony, you pointed out something that many people may not realize, and I quote, "The primary purpose of health insurance data collected by state regulators today is to monitor the solvency of private health insurers," and that, quote, "enforcement of consumer protections in health insurance today is largely triggered by complaints." I think the average person is or would be surprised to hear this. So who does monitor things like accessibility, affordability, or security of private health insurers, or how accurately or fully they pay out on claims?
It is not well monitored or consistently monitored today. I think state insurance regulators strive mightily to protect consumers as best they can. Their resources are limited.
Would you describe the state regulators as reactive to consumer complaints rather than proactive?
A lot of it is reactive, oftentimes in response to a complaint. Even as little as one complaint, a state regulator may initiate a broader investigation of a company or of a pattern of practices. So I don't mean to suggest that state regulators aren't out there giving it their best effort, but they are very strapped in terms of resources. They are very broad in terms of the jurisdiction that they need to keep an eye on. And with limited resources, I mean, if I were one and I had the limited resources, I would probably start with solvency myself, because if a company goes under, then no claims will be paid for anybody. So that's not an illogical place to start, but there are not enough resources to monitor closely what needs to be monitored. And with health insurance, that's a very transaction-heavy task to accomplish.
Do private health insurers themselves keep data on complaints made against them that can be reviewed?
That can be reviewed?
Yeah.
I don't actually know what data they would keep. All insurance companies have a compliance office with a lot of attorneys, and I'm sure they at least have a pretty good idea of what complaints are being filed, and they have to keep records. I mean, this is why you get urged to put everything in writing when you're communicating with your insurance company, so that there will be a record somewhere.
Okay, my time's expired. I'm going to go to my colleague for 5 minutes, and then we'll go to one more and final round of questioning.
Thank you, Mr. Chairman. Mr. Cannon and Ms. Poltz, thank you for being here. Mr. Cannon, let me ask you about this idea of interstate insurance, broadening the field, increasing the market, increasing competition. In the first panel, I believe Dr. Pino and Mr. Potter talked about the cartel that exists in the insurance market right now. Their solution was to have the government compete. That's, to increase competition by having this so-called public option. The approach I'd prefer is this interstate market. Tell me your thoughts on that. What the research shows, it's getting this is now being debated a lot and talked about as a possible improvement. Let me hear your thoughts there.
Well, I think that the insurance markets in most states are not unlike a cartel, and I think the reason is because each state sets up barriers to competition to protect their domestic insurers. What those are essentially state licensing laws. Now, there's nothing wrong with a state licensing law per se, but what these laws do is they say unless your insurance policy is licensed by this state, say the Commonwealth of Virginia, then you may not sell it to residents of this state. And so what that means is that residents of Virginia cannot purchase a health insurance policy that's available in Maryland or in
Right.
North Carolina.
Understand.
That's particularly cruel, I think, to residents of, say, New Jersey, who face some of the highest health insurance premiums in the country. They cannot purchase health insurance from across the Delaware River in Pennsylvania, where it's often less expensive. So what happens, so I do think there is insufficient competition in insurance markets. The President and other supporters of a new government program have said that that a new competitor can keep insurance companies honest. If that's the case, then I think that dozens of new competitors would do an even better job.
Right.
So that if Congress, using its power under the Interstate Commerce Clause of the Constitution, were to say, look, states can license health insurance, but they cannot prohibit their residents from purchasing health insurance licensed by another state. What that would do is it would bring new entrants into the markets in each state, give individuals and employers a lot more choices of health insurance plans, and increase competition. What it would also do is it would give individuals and employers the power to avoid unwanted, costly state regulations. A lot of state regulations are, in fact, consumer protections. Solvency standards that Ms. Politz was talking about are, I think, a prime example. But when you start looking at how the states require consumers to purchase 40 different types of mandated benefits that they may not want or need, or try to impose hidden taxes on the healthy in order to subsidize the sick.
That's where savings can take place, sure.
Those are regulations that increase the cost of insurance and make it unaffordable for some people. So you can't really call them consumer protections if they're keeping people from purchasing health insurance. And I think that letting people purchase insurance across state lines would allow people to.
Thank you. Ms. Paul.
The proposals to allow sale across state lines that have been in the Congress to date are really a prescription for insurance fraud. There would be little practical ability of the licensing state to regulate insurance sold across the 50 states. Imagine if the Ohio commissioner had to keep track of policies that were sold in California and Texas and New York. They're not set up for that. It's the notion of escaping mandated benefits is a total red herring. The reason that health insurance costs more in New Jersey compared to Maryland, where I live, which has been cited as the champion of mandated benefits, supposedly we have more in Maryland than anywhere, is that in New Jersey, everybody has to be offered health insurance. You can't be turned down because you have cancer. And in Maryland, you can. So it's cheaper. And insurance will
Mr. Cannon
always...
talked a lot about that in his previous question.
I think we have to come back to what is the basis of competition in health insurance right now. And it is competition to avoid sick people and their costs. And the more you dilute oversight and regulation, the more easy that will be, and the more consumers will be at risk.
A response from Mr. Cannon.
Karen raises a couple of important issues. One of them is, how do you enforce these rules that are written by an out-of-state legislature or insurance commissioner? And I think there's a fairly straightforward way of doing that. You have those regulations, whatever they may be, incorporated in the insurance contract, which could then be enforced in the purchaser's home state and in their courts. So and then the domestic, the purchaser's insurance commissioner could even play a role there. What's important is that the individual consumer or the employer be able to choose the rules, and they could be enforced at home without having to rely on an out-of-state insurance commissioner. As for the cost of mandated benefits, the cost estimates vary, but the Commonwealth of Massachusetts recently estimated that the benefits that are mandated in that state add 12% to the cost of premiums. So that's a substantial chunk of money.
Sure. Mr. Chairman, it looks like just you and me. I yield back to you.
Just you and me. This town is big enough for both of us. I'd like to go back to Ms. Politz. I'd like to talk to you about standards of care and a possible scenario. Are you aware of any data on the inconsistent application of standards of care by private insurers? Is it possible that within taking two different people with the same illness who are insured by the same private health insurer, that they'll be treated differently by the insurance company? Is that possible?
I believe it's possible, yes.
And so is there any guarantee that if a person buys coverage, it will guarantee coverage?
Not an ironclad guarantee, no.
Pardon?
Not an ironclad guarantee, no. There is a contract, but it's
But there's
very
no
hard.
guarantees.
That's correct.
I'd like to ask you about lack of transparency in private health insurance as compared to Medicare. Congress and the general public are able to examine and debate the reasoning behind how Medicare pays for medical care, but the private health insurers keep their decision-making process and guidelines hidden behind thick books of confusing terminology. In other words, Medicare's actions are transparent, but private insurers are not. But they provide the same service, ostensibly, to cover medical expenses. Now, is there any justification to keeping insurance company definitions of medical necessity proprietary?
I don't think so, no.
And why would the insurance company want to keep that information proprietary?
I believe they'll argue so that doctors and other providers don't try to game the system and sort of code their billing so that, it matches up what the, what the guidelines would be. But I think you heard testimony on the earlier panel that there is also an effort to just, kind of try to hide the ball and try to, create options for the insurance company to deny claims if they feel like they want to do that.
Are there any data nationally about either the frequency of wrongful denials of claims or of unjustified reviews or appeals?
There are not good, consistent data. I tried a couple of years ago to study the results of even external appeals programs, and the data are very sparse. What you can find is suggests that we need to be doing a better job and looking much more carefully and not relying on this sort of end result of a patient having to go through all of the steps and appeals before they can get to a system where records will be kept.
Anything else you wanted to add about that that you haven't told this committee about the data collection?
I really do think, Mr. Chairman, that we need to think carefully about the ways that insurance companies compete now to avoid paying claims. Certainly there are reasons why we don't want to pay for care that's not medically necessary. We don't want to pay for fraud. I mean, there are reasons for vigilance for sure. But I think we need to think from the patient's perspective about what we need to track. So that we can make sure that decisions are justified, that they're backed up, that they're consistent, and that they're in the patient's best interests. And then build our data reporting requirements from that exercise. I think we need a much more proactive and pro-patient approach to data gathering from health insurance companies, and I hope that will be a central part of any health reform legislation that gets enacted.
I'd like to ask a question of Mr. Cannon. You're here representing the Cato Institute, and I've always found very handy this Constitution of the United States, which comes from the Cato Institute, including its introduction. Under our Constitution, the General Welfare Clause, which there's been a lot of discussion about, there are some of us who believe that both the Preamble to the Constitution and Article 1, Section 8, in describing the general welfare, that as we evolve as a nation and have specified health care, retirement security as part of the general welfare, that a logical extension of that would be to have health care for all, guided by the principle of enunciated in the Constitution, both in Article 1, Section 8 and the Preamble. Tell me how you see that.
The question is about the general welfare clause of the Constitution. There is a difference of opinion among legal scholars about what that means. I'm not a constitutional scholar, but let me give you my best take on what that disagreement is. There are some that read that as an expansive grant of power that would, say, give Congress the power to, the constitutional authority to enact, say, a single-payer system or make health insurance compulsory for all Americans. I think that the perspective of Cato's constitutional scholars is that if that were true, if the framers of the Constitution meant for the General Welfare Clause to be such a sweeping, broad, comprehensive grant of power from the states to the federal government, then the rest of the Constitution would be superfluous. They wouldn't have had to enumerate all the other powers in the Constitution because the General Welfare Clause would have taken care of everything. So the very structure of the Constitution itself, I think, argues against a broad or the sort of expansive interpretation of the General Welfare Clause that you suggest.
Well, one of the things that that I've always been impressed with is the preamble which Cato provides to the Declaration and the Constitution. And one of the things they say in there, my colleague, is that it's not political will but moral reasoning which is the foundation of the political system. And some of the issues that are being brought to us about conditions relating to health care in America are laden with moral consequences and moral overtones, and there's like an underlying reality of whether if health care is a privilege based on ability to pay, or is health care a fundamental right in a democratic society. There's like this arc where you go from economics, which can be amoral, to the imperatives of a democracy that relate directly to morality. And I just, that's in a way that's part of the backdrop of this national discussion we're having right now. Is it a right or is it a privilege? And this is part of our unfolding democracy here, trying to dissolve those, trying to decipher what the meaning of this document is, and also doing it within the context of what our present day needs are, and what the very human conditions we find ourselves in, and the underlying morality of, is it immoral for somebody to be denied care even when they're paying for policy? These are questions that we have to deal with here. I appreciate having the chance to share that with you. Mr. Jordan, you can conclude this hearing.
All right, thank you, Mr. Chairman. Let me just go to the premise. Many of the witnesses in the first panel, the premise was the government can do it better. We know that there's been problems with the way insurance companies deal with patients and sometimes some of the things that take place. But this idea that government can do it better, I'd like your thoughts on that. In light of Congressional Research Service said that over 1 billion claims are submitted each year to Medicare, 10% of those claims are denied. Attorney General Holder, I have a quote here, said, "By all accounts, every year we lose tens of billions of dollars in Medicare and Medicaid funds to fraud." So your thoughts on we met with healthcare professionals. We did healthcare roundtables in our district over the recess. And, we had so many people tell us that, government's already 50% of the healthcare market right now, and that providers don't get compensated fully for the care they provide when they treat folks in our Medicare and Medicaid system, and therefore the folks who are in the private insurance have to pay more because just the way the system's set up right now. So I'd like both your thoughts. I'll start with Mr. Cannon on this premise that is been so kind of underlies the entire hearing today on somehow that the government can do it better, because as you can gather, I have real reservations about that.
Well, I think, Congressman, that the state of America's healthcare sector right now is pretty good evidence that the government does not do a very good job of managing healthcare. And I'll give you a couple of examples. You brought up the Medicare program. That program it has been estimated that 1/3 of Medicare spending does absolutely nothing to improve the health or improve the health of patients or improve patient satisfaction, provides no value to them whatsoever. It's often cited that we have, so that's an enormous amount of waste, much even larger than the estimates of fraud in the Medicare program. It has been estimated that as many as 100,000 Americans die every year due to medical errors in hospitals. I submit that Medicare is probably the biggest reason for that, because Medicare's payment system actually penalizes doctors and hospitals when they succeed in reducing medical errors. It makes it a losing business proposition. Rather than have competition between different payment systems that bring out different dimensions of that would improve all dimensions of quality, Medicare gives us good marks on some dimensions of quality, but absolutely horrible marks on other dimensions. One of the biggest problems that the president talks about is the problem of pre-existing conditions, people with high-cost illnesses who lose their coverage and then cannot afford the premiums that they're charged on the individual market. That is a problem that has been fueled by government for 60 years. And the reason is that 60 years ago, the government created a tax preference for employer-sponsored insurance coverage that has given us the employer-based system that we have right now that is so cruel, and to use the chairman's words, immoral, that it takes insurance away from people at the moment they need it most. When they lose their jobs, they lose their incomes. And if those people are sick, then they've got a pre-existing condition. They're not going to be able to get coverage. And if I may finish, one of the studies that I cite in my written testimony looks at the empirical looks at the data and finds that people who purchase insurance directly from an insurance company, people with high-cost illnesses who do so, are half as likely to end up uninsured as people who purchase high-cost patients who purchase health insurance from a small employer.
Yeah. One of the things we should do, it's in the legislation I've co-sponsored, is for the family that has to go out and buy it on their own in the market, they should get the same tax advantage that we give to employers who provide it to their employees.
And that problem has been in place for 60 years now.
That's
and the government has yet to
number one
correct
thing
it.
we have to do, or one of the key things we have to do. Ms. Politz, I'm sorry, go ahead.
Oh, no problem. I think I think two real differences. One is about accountability, and there is a different level of accountability for government than there is for the private sector. There just is. I think we should try to enhance and strengthen accountability in the private sector with much stronger oversight and regulation and enforcement, regardless of how you end up structuring health reform. I think that's essential. But the government programs will always be accountable in a different way directly to the voters. They'll always be open in a different way compared to commercial plans. That's the way we've set up our government.
I think you get an argument from Mr. Cannon and many of us that a real marketplace, they're accountable directly to the consumer.
Well, but
that's
my second point.
That's where we need to be headed, is to a true marketplace.
And that's my second point. A marketplace of competing insurance companies will always, in health insurance, compete to avoid sick people. That is the overpowering incentive. It beats everything, and it always will. Even in a more regulated marketplace, even in a more transparent place, you're always going to be trying to catch up with that. Introducing a public component to that, it's kind of a funny notion. It's not like the government is going to compete to make more profits than Blue Cross or WellPoint. It's that the government will be there offering a choice that isn't motivated by that.
We need to be clear on this point. If there's a public option, eventually the public option will dominate. I mean, even Congressman Frank has said that a public option will lead to a single-payer system. That's this idea that somehow it's not going to do that. I don't think flies. I think most Americans have already figured that out, and that's why they're concerned about this.
But Mr. Jordan, I was on the board for several years of a public program in my state where I live, our state high-risk pool, and it was administered by a private insurance company, and so they know how to administer claims, and that is definitely its own art and its own skill. And as the consumer rep on the board, I would ask questions. Why do we have so many denials of pre-authorization, for example, for mental health services? That turned out to be one of the biggest services that any of our patients used, even though that wasn't the major diagnosis. It's very stressful to be sick. People need help. And one of our leading sources of complaints had to do with denials for mental health services. And so I said, why is that? Why are we denying all this care? Well, it turned out it was paperwork. People were supposed to jump through all these hoops and get pre-authorization. They had to do it within a certain number of days. And it was just a load of hoops that they had to jump through. And I said, well, okay, once they go through all these hoops, how many of them were actually denied? And we had thousands of denials. And they said 7. And I said, really? Then why are we doing this? Why are we making them jump through all these hoops? Oh, they said, this is saving you a lot of money. I said, I don't want you to save us a lot of money. We're here to pay for care. We're a high-risk pool. They're sick. No one else will take care of them. This is our job. This is what the taxpayers have given us tax dollars to do. Let's stop doing that. We did that. I can't imagine that would happen in the company that Dr. Pino used to work for. That it's just a different incentive. It competes on a different way. And I think we need to create a different standard for covering health care. And if private insurance companies can't compete against that and survive, well, so what? I mean, we took care of the patients who were sick, and isn't that what this has to be about primarily? It seems to me that has to be where we start the discussion.
We thank the gentlelady. I want to thank Mr. Jordan for his participation in this hearing, and thank both of the witnesses from the second panel for their participation. As my friend is leaving the room, I just wanted to comment, and staff can relate this to him, that there are some cases, I suppose, where a public option may lead to a single-payer system at some point. I mean, I actually am the co-author of a bill to create a single-payer system, and I'd like to see a single-payer system. We have 85 members of the House who have signed on to a bill, H.R. 676, a bill I drafted with Mr. Conyers. But that bill, in its fullness, is not likely to have hearings, and while there might be a vote on it, it needs a movement behind it that doesn't, that needs a little more strength. So while some public options may lead to single payer, I would just like to offer the opinion that it's unlikely that the current status of the public option that is suggested in H.R. 3200 would lead to single payer. O has said in one of its studies that 9 million people at most would be covered by any kind of a public option. That the first iteration of that plan was to have 129 million people covered by it. So if you have 9 million people, that particular plan may not pose much of a risk, or actually, frankly, a competitive position vis-a-vis the private insurers. I just wanted to mention that since we're talking about public options. You're much appreciated for the time that you've spent, for your patience, and this committee stands adjourned. I want to remind people that tomorrow we will hear from executives from 6 of the major health insurance companies so that we can follow up and ask them some of the questions that were raised in today's hearing. We all are very appreciative of your presence. Committee stands adjourned.